Everyone this morning to our June grand rounds. This June 1st, 2023, our speaker today is one of our fourth-year residents, Dr. Laura Cordonnier. She received her Bachelor of Arts degree in chemistry, as well as a minor in physics, summa cum laude at Miami University of Ohio in 2014. She completed her medical training at Rocky Vista University College of Osteopathic Medicine in Parker, Colorado in 2019, and is currently a fourth-year resident in psychiatry here at U of L. During her residency, she served various roles in the resident advisory committee, including social chair and vice president. She was also a recipient of the John Bell Award in Emergency Psychiatry. She's going to speak to us today about methamphetamine use in the United States, an epidemic, a very timely topic. I'm looking forward to hearing this, and I hope you are too. Please lead us on, Dr. Cordonnier.
Thanks, Dr. Caudill, for the introduction. So we'll go ahead and get started. I did view the disclosures form prior to this on the screen. I do not have any disclosures. So we will be talking about methamphetamine use today in the United States and kind of considering if that use is an epidemic in the United States. So our learning objectives for today are to review the history of methamphetamine and amphetamine use, to learn about how methamphetamine works and the effects of use of methamphetamine, to review the diagnostic criteria for disorders that are associated with use, discuss trends in methamphetamine use in the United States and their impact on the healthcare system, and also to discuss treatment options for methamphetamine use disorder. This is slightly redundant, but our outline of our talk will be discussing history of amphetamines and methamphetamine. Then we'll transition into talking a little bit about how meth works. Then we'll talk specifically about some of the diagnostic criteria for those disorders, speak about the effects of methamphetamine and how we manage it acutely, and then also review trends in the United States via various different studies that have been conducted, and then discuss various treatment options. So to get us started, let's talk a little bit about the history of amphetamines. So amphetamine type stimulants were initially developed as a man-made alternative to the ephedra plant. You can see the ephedra plant here on the right. Methamphetamine itself was actually first synthesized by a Japanese chemist from another stimulant in 1893. Later on in 1919 is when the first crystal methamphetamine was formed by a different Japanese chemist. And the formulation of the crystal methamphetamine really streamlined the process of being able to produce meth compared to how it was made prior to that time. And then fast forwarding a little bit to 1932, we see that pharmaceutical companies began marketing amphetamine inhalers for asthma and nasal congestion. Benzedrine is one that was very common back in that time. It was actually initially available over the counter and later actually manufactured in pill form for the intention of use for narcolepsy. So you can see over here a couple of examples of those inhalers. And interesting, we have, a little girl on this one, and it says, safe for children and adults. So this was used in a wide range of ages back in that time frame. And like I mentioned, was over the counter at that point. We see that, by the late 1930s, after production of some of those medications, that psychiatrists and neurologists were using amphetamines to treat mild neurotic depression. They did see in the 1930s that there was, so were some instances of documented amphetamine-induced psychosis. However, it was typically attributed to being latent schizophrenia that was being unmasked by the drug rather than being attributed to perhaps the substance itself as far as being an effect of it. Moving forward, we see that during World War II, German pharmaceutical company began marketing methamphetamine tablets as a non-prescription drug. This was not specific to German pharmaceutical companies. There were various other pharmaceutical companies in that time in the United States and otherwise that were producing very similar substances under different brand names. These were used very, very frequently by soldiers in that time for heightening alertness and increasing their willingness to take risks and reducing fatigue. So as I mentioned, the German, soldiers use this, the British, the United States. Interestingly, the Japanese kamikaze actually, before those pilots were sent on their mission or their flights, they actually were given very, very, very high doses of methamphetamine, probably for the purposes that we just alluded to, as considering, willingness to take risks like that. We see that, by 1941, annual sales of Benzedrine tablets are up to about $500,000. As you can imagine, in that time frame, that's a lot of money. And then by 1945, the civilian amphetamine tablet sales were actually up to about $2 million. We see that in December of 1943, Desoxin, which is methamphetamine hydrochloride, so it's the brand name of methamphetamine, was approved by the FDA. By around the 1950s, Benzedrine actually began being used more and more frequently and recreationally, and was popular in that time frame for that use, in addition to the previously documented, indications for or reasons that it was created. And that term, they were called bennies back then. And then in 1959, the FDA began requiring prescriptions for Benzedrine, so it was no longer offered over the counter. We see that by the 1950s or 60s, it was widely prescribed for depression, specifically anhedonia, as well as obesity, reaching the peak of 31 million prescriptions in the United States in 1967. So again, here's an example of some of those tablets. This pharmaceutical company here listed was one of the major ones initially that prescribed and had a more of a monopoly over a lot of the amphetamine substances that were produced. However, eventually, a lot of other pharmaceutical companies began creating their own spin-offs or versions, and so that really also contributed to the increase in amphetamines around that time. So here we can see a couple of advertisements. These are from around the 30s to the 50s, and so these were out of, I think, just newspaper article, newspaper ads, something like that. So you can see that they're advertising use of amphetamine specifically for depression, promoting that they, help with cheerfulness, mental alertness, and optimism. And you can also see that they had a parenteral in a tablet form around that time frame. And additionally, promoting Benzedrine tablets specifically for depression. So moving forward, by around 1960, there's more evidence that amphetamines actually can be addictive as opposed to being "quote unquote" habituating. Initially, that was what was asserted, and a lot of the literature or justification for using this type of substance. And so, we're beginning to see that, hey, maybe this is not so good, or maybe there are more downsides to this than we originally had believed. By the late 1960s, according to the FDA in the United States, up to half of 10 milligram amphetamine tablets that were manufactured by various drug companies were actually being diverted from medical channels. So we already begin to see that, in the late 60s, there is an issue with diversion of amphetamines. In 1970, they actually went ahead and finally scheduled or created the class of scheduling of various substances, placing prescribed injectable amphetamines into Schedule 2, and then oral amphetamine products into Schedule 3. So as a reminder, Schedule 2 substances have a high potential for abuse, with use potentially leading to severe psychological or physical dependence, versus a Schedule 3 drug that is considered to have moderate to low potential for physical and psychological dependence. And so really, even in that time frame, injectable amphetamines were not very commonly utilized. So really, there wasn't a significant decrease in prescribing after amphetamines being placed, being scheduled. And then, by mid-1971, they actually did go ahead and move all amphetamine products into a Schedule 2 class, which did ultimately lead to a decrease in prescribing. Many providers, as they are these days, are more hesitant to prescribe controlled or scheduled substances. Of note, from about the 20s to the 70s was considered an epidemic for amphetamines or amphetamine use, not specifically methamphetamine, but amphetamines across the board. Based on the literature I was reading, it really seems like it was attributed primarily to, being iatrogenic in nature, as far as due to kind of what we've covered so far with a lot of the substances being formulated and prescribed over the, offered over the counter, eventually prescribed, and kind of prior to us realizing that there are some negative effects, which obviously we can make a lot of comparisons to other situations, such as with the opioid epidemic. So even back then, we were kind of having some issues or problems with amphetamines in that regard. So then we see kind of after 1971 that the FDA kind of, retroactively declares that, okay, amphetamines maybe aren't, of great, proven efficacy for, long-term use for obesity specifically, and then also for depression. And then, since then, around the late 1980s, we've seen, a significant resurgence again in amphetamine use. And this is in part, due to increased illicit supply. So um, the cause of increased use, it seems to be a bit more due to um, other resources other than solely prescription, rates increasing and things like that, which we'll get into a little bit further as we move forward. So we see that in the 1980s, the United States began to tighten the sales of ephedrine, which is a pharmaceutical precursor that's used to make meth. And people actually began using pseudoephedrine to make meth instead. So pseudoephedrine, I'm sure most of us are familiar, Sudafed and various other nasal decongestants that are offered over the counter utilize that medication. So taking a look just briefly, just kind of here are some different names or things that methamphetamine can be called, like sort of street names. I won't read through all of them, but you can just take a look. A lot of times, we'll hear about ice or um, that's one of the most common ones that you'll hear people talk about, speed as well. But there's a list. There's a lot of different names. I'm sure it's ever changing as well. So typically, meth initially was created, like we talked about before, it was more like a pill or a powder form. And then there was the formulation of that crystal meth later, and that's going to appear more like glass fragments. Meth can be used via various methods, including being swallowed, snorted, injected, or smoked. So you can see the top image is going to be your kind of powder form of meth. The middle is crystal meth, and the bottom are meth rocks. So jumping forward to more of the present day in our 2000s, we see that there is methamphetamine still produced in domestic labs in the United States, but typically when we find this, it's going to be smaller scale production, and so this is kind of again what those people who were perhaps purchasing massive amounts of pseudoephedrine, that would be kind of for more of these home lab type purposes. However, we do see that the vast majority of methamphetamine use in this day and age is really from Mexican drug trafficking organizations. So they've been able to, produce massive amounts of the substances, and just distribute it across the border into the United States. They have been able to, create increasingly potent forms that are available at lower and lower costs. Um, so they have different ways of creating the drug than using pseudoephedrine in those more small scale situations or operations that occurred more so frequently prior to the 2000s. What we are seeing of significant note is that oftentimes more recently it's being cut with fentanyl as well. So you can imagine that if somebody's using methamphetamine and has been for years and years, and they get some new methamphetamine from that's come from some of these sources that if they're naive to opiates and use the normal amount of meth that they typically would, that could lead to some really awful negative repercussions, and we'll get into that a little bit later as well. Also, there's increasing rates of IV use, which is obviously going to have implications as far as transmission of various infectious diseases. So we do see that the Combat Methamphetamine Act, Epidemic Act, was passed in 2005. That actually required retailers for non-prescription meds, so over-the-counter medicines, including pseudoephedrine, ephedrine, or phenylpropylamine, to place those products behind the counter or in a locked cabinet. So for I guess a lot of us were alive during that time frame, but so they actually, I remember, Sudafed being over the counter, you could just go and pick it up. And so since then, it's been moved behind the shelves and back in the pharmacy with the rest of the prescription medications for the purposes of limiting and monitoring people purchasing massive amounts so that people domestically can't be producing methamphetamine illegally. Um, of note, Desoxyn remains on the market with FDA indications for ADHD and for short-term use specifically for obesity. Of note, there are many other um, amphetamines that are, utilized and still prescribed today for the purposes of ADHD. We aren't really going to get into those as much during this talk, but it is something to kind of think about as we move forward in our discussion. So you can see at the bottom here, there are a couple of pictures of, sort of the show, just kind of representing the massive bulk quantities of methamphetamine that are being produced primarily in Mexico and trafficked up here. So shifting gears a little bit, let's talk a little bit about how methamphetamine works and what it does. So methamphetamine works by causing the release of dopamine, norepinephrine, and serotonin via various different mechanisms. These include increasing levels of monoamines, which forces the monoamines out of their storage vesicles and into the synaptic gap, making dopamine transporters work in reverse. Additionally, they block the reuptake. It blocks the reuptake of monoamines by inhibiting the activity of monoamine transporters. It decreases the expression of dopamine transporters at the cell surface. It increases cytosolic levels of monoamines by inhibiting the activity of monoamine oxidase. And lastly, it increases the activity and expression of dopamine synthesizing enzyme tyrosine hydroxylase. So in the next slide, we'll take a look at some of those mechanisms in a picture form for those of us who are more visual learners. You can see the structure of amphetamine and a methamphetamine. They only differ, not surprisingly, based on the name of methamphetamine by a methyl group off of your nitrogen. That doesn't seem like a significant difference. However, it actually chemically is, in the sense that that extra methyl group makes the more lipid soluble, which thereby allows it to, more rapidly penetrate the blood-brain barrier. We know that clinically, this correlates with having faster rate of action essentially in the brain. So you're going to get more of a mental change or a high, which is typically what people use substances and illicit substances for. It's what they're trying to achieve. So you're going to get that more rapidly using methamphetamine compared to an amphetamine. So obviously that could lend itself to more concern about, addictive properties and being forming dependence. So as promised, here's kind of a visual look at some of those mechanisms by which methamphetamine works. So we see that it primarily functions, or at least heavily functions in the caudate, the ventral striatum, and the external globus pallidus portions of the brain. So you can see in this image above that we have normal functioning at a synapse. So we've got our dopamine transporters here, and we've got our monoamine transporter here. So we can see that our dopamine transporters are doing what they should. They're pumping the dopamine out of the synapse back into the neuron. We also see that the monoamine oxidase or the monoamine transporter is pumping, the dopamine back into the synaptic vesicles. Down below, we see the methamphetamine induced changes. So we can see that, as we talked about previously, the dopamine transporters are being reversed as far as their directionality of pumping the dopamine. So instead of our monoamine transporter putting the dopamine back into its vesicles, it's actually releasing those back into the neuron, into sort of the and then additionally, we see that our dopamine transporters are working in reverse as well. So instead of reuptaking or removing dopamine from that synapse, we're actually pumping more and more dopamine into that synapse, which of course is going to cause some of the effects that we'll talk about here shortly. So let's talk briefly about sort of some of the criteria for various use disorders that are related to methamphetamine. So methamphetamine use disorder follows under the category of stimulant use disorder in the DSM-5. So for the purposes of stimulant use disorder in the DSM-5, it relates specifically to any sort of amphetamine substance or caffeine. So we know that, cocaine, for instance, is a stimulant as well, but it actually has its own use disorder in the DSM-5. So when we're looking at stimulant use disorder, most of the criteria for use disorder are going to be very similar. It's just specific to that substance, but we'll briefly kind of run through what the criteria would be to diagnose someone with this. So, it would be use leading to clinically significant impairment or distress that's manifested by at least two of the following criteria that occur within a 12-month period. So the criteria, two of which would need to be met, would include using more over a longer period of time than the person intends, having a persistent desire to use or being unable to or unsuccessful in reducing their amount of use, spending a lot of time trying to either obtain the substance or the stimulant, using the stimulant, or recovering from the effects of it, having, urges or desire to use or cravings, um, having their use result in failure to complete certain significant roles or responsibilities in their life, such as work tasks or school things related to school or their home obligations or responsibilities. um, that these people continue to use despite awareness of interpersonal or social problems that may be linked to their using substances or stimulants. um, there's a reduction in or not no longer participating in important social, occupational, or recreational activities that maybe they were previously involved in. Recurrent use in hazardous situations, so an example of that would be those people who continue to use IV, and maybe are using needles that they know aren't clean, um, continuing to use despite awareness that their use is resulting in physical or psychological problems, that they develop tolerance to the substance or the stimulant. And these would be either, shown by needing, higher and higher amounts to achieve intoxication or the desired effect that they're looking for, or having, significantly decreased effect with continued use of the same amount of substance. Last criteria or option would be withdrawal, which is manifested by a characteristic withdrawal syndrome. We'll talk about that here in a minute, or using to relieve or avoid withdrawal symptoms. So there is classification of the use disorder as far as it being mild versus moderate versus severe. For a mild disorder, somebody's going to have 2 to 3 of those symptoms we just talked about. For a moderate disorder, they're going to have 4 to 5 symptoms. And to classify as a severe disorder, they're going to have 6 or more of those symptoms. So taking a look more at acute intoxication and what that diagnosis entails, it requires at least 2 of the following shortly after the person uses the substance or the stimulant. So those could be tachycardia or bradycardia, pupillary dilation, elevated or lowered blood pressure, perspiration or chills, nausea or vomiting, evidence of weight loss, psychomotor agitation, muscle weakness, respiratory depression, chest pain, or cardiac arrhythmias, confusion, seizures, dyskinesias, dystonias, or coma. Of note, this also requires there to be a clinically significant problematic behavior or psychological change that's present. There are specifiers for stimulant intoxication. For example, you could have stimulant intoxication with perceptual disturbances. This would be classified when or considered when someone's having hallucinations that occur when they have intact reality testing, or when they have auditory, visual, or tactile hallucinations that are not in the context of them being delirious. Taking a look at stimulant withdrawal, the person must have dysphoric mood that develops within either hours or to days of ceasing or reducing the use of the stimulant. Typically, the stimulant use has been heavy or prolonged. They also have to have 2 of the following, which could be, fatigue, vivid, unpleasant dreams, insomnia or hypersomnia, increased appetite, or psychomotor retardation or agitation. I do want to point out, I didn't write it out on these slides, but for all of these diagnoses we've covered so far, there is always sort of the caveat or the additional criteria that the symptoms that you're seeing in order, or you're using in order to diagnose this person, are not due to either some other mental ailment or illness, or say, for instance, schizophrenia or a primary psychotic disorder, or the result of some sort of medical issue. So they have to be kind of outside of the realm of those things. So kind of taking a look on that note into consideration of a primary psychotic disorder versus a substance-induced psychosis. So this chart's kind of specifically looking at for a person who is utilizing something like methamphetamine or a substance, how do you kind of help, or what information can help you to distinguish between if it's a primary psychotic disorder versus if it's a result of the substance use? So for the primary psychotic disorder, symptoms are typically, much more so in excess of what you would expect based on, the amount or type of substance that the person's using or how long they've been using it. The history of the psychotic episodes may not be, substance related. So they may have episodes of psychosis outside of the context of recent substance use. Um, Additionally, a huge kind of diagnostic helper in determining and deciphering these things is that the psychotic symptom onset typically precedes the onset of substance use. That's a good indicator that you're not dealing with totally just a substance induced psychosis. And lastly, psychotic symptoms are going to persist for at least 1 month after cessation of intoxication or acute withdrawal from that substance. On the flip side, we look at, substance-induced psychosis. So oftentimes you're going to see the presence of prominent hallucinations or delusions. Not to say that that's not possible with a primary psychotic disorder either, but you'll see that these hallucinations or delusions develop generally, during or soon after intoxication or withdrawal from that substance. And typically, it's a substance known to cause psychotic symptoms such as methamphetamine. The psychotic symptoms are not a part of a psychotic disorder that's not substance induced. So again, they're not, falling under the umbrella of being, a primary psychotic disorder. If the person's previously diagnosed with schizophrenia, it's going to be a lot harder to discern, if that's substance induced, and probably you can't really attribute it to substance if they already carry that diagnosis. And lastly, symptoms cannot occur only in the context of a delirium, which is kind of what we touched on with acute intoxication as well. So let's talk a little bit about the effects of methamphetamine use. They're very, very overreaching, a wide range of symptoms and side effects, as well as associations of other health risks. So this is not by any means a totally inclusive list, but I wanted to hit on some of the high points and significant things. So looking at our cardiopulmonary system, we oftentimes see elevated blood pressure, tachycardia, and angina or chest pain. Additionally, you can see arrhythmias, vasoconstriction, acute vasospasm, acute myocardial infarction, atherosclerotic coronary artery disease, dilated cardiomyopathy, and pulmonary hypertension, as well as acute respiratory distress syndrome. Of note, I thought it was very interesting that a atherosclerotic coronary artery disease was included, but this is suspected to be due to methamphetamine causing sort of a pro-inflammatory state in the body. And so we know that increased inflammation can also, lead to coronary artery disease and damage to the vessels. So that is kind of the proposed mechanism. Obviously, it's not terribly intuitive, just because oftentimes when you see people that use methamphetamine, they may be very skinny and have lost a lot of weight. They may not have a high hemoglobin A1C. They may not have high cholesterol. So a lot of those kind of typical risk factors or things that we associate with it, they may not have, but it's really that inflammatory state that causes this to occur for them. Of course, there are significant implications, from a cardiovascular standpoint, with these side effects or results of use. Namely that, acute myocardial infarction obviously can lead to death. And so, we will talk a little bit more about that moving forward. Additionally, hyperthermia can be seen frequently with methamphetamine use. That can actually lead to end organ damage. Again, so very dangerous and some serious, potential health risks associated with that. Rhabdomyolysis and acute kidney injury are often seen, as well as we touched on earlier, infectious disease transmission. So HIV, viral hepatitis, STIs. Of course, this is going to be much more associated, like we mentioned, with IV drug use and using dirty needles. So taking a little bit more of a look at sort of things that are more relevant to us in the psychiatric world, there are, a very wide range of central nervous system effects of methamphetamine use as well. So oftentimes, if we see a patient that comes in and is intoxicated on methamphetamine, they may seem like they're in a euphoric or an energetic state. They're increased, may have increased alertness to the point of, hypervigilance, increased libido, psychomotor agitation. They may have irritability or anxiety, mood disturbances or affective lability. Like we've touched on previously, they can have psychotic symptoms due to the increase in dopamine. So this can present as paranoia, auditory, visual, or tactile hallucinations, ideas of reference, persecutory delusions, and a lot of these, symptoms, including the delusions, can result in violent behavior in certain instances. Of note, the tactile hallucinations oftentimes you'll anecdotally when we hear oh, well, someone's complaining of feeling like there's bugs crawling under their skin, that's very very um, indicative of maybe perhaps someone using methamphetamine. Additionally, seizures can result from methamphetamine use. And lastly, kind of touching on that pro-inflammatory state that methamphetamine causes in our bodies, microglial cells, which are macrophages in our brain or in our they can be activated, which ultimately results in secretion of some of those pro-inflammatory molecules, which actually leads to neuronal injury as well. So that inflammatory state, not just dangerous to our vessels or our cardiovascular system, it is just diffuse across the entire body, including the brain. So just running through some more information on methamphetamine-induced psychosis. Typically, it develops from hours to days after use. Users who meet the criteria for dependence, which is also, severe use disorder, are 3 times more likely to experience psychotic symptoms compared to users who are non-dependent. So we know that, with ongoing and use over time, or, heavier use as far as quantity, that, the more that somebody uses this substance, the more likely they are to develop psychosis as a result of it. We see that between 26 to 46% of individuals with methamphetamine dependence have induced psychosis. Risk factors for developing psychosis include polysubstance use, psychiatric comorbidities, especially the affective disorder or antisocial personality disorder, as well as a family history of psychiatric disorders. Of note, there is a lot of kind of overlap between, patients with schizophrenia and patients with methamphetamine-induced psychosis. There are a lot of sort of similarities as far as, trends in family history and some of the factors or risks that predispose people to, um, you know, methamphetamine use disorder or psychosis. So the recovery period from psychosis on average is within 1 week. However, as a lot of us have probably seen in EPS, it can convert over a period of years to a primary psychotic disorder. And so when it would technically be considered a primary psychotic disorder would be when you have symptoms that are present for, longer than 6 months after abstaining or stopping the use of methamphetamine. There is a lot of kind of argument or lack of agreement in the literature as far as do you still, at that point in time, do you consider it a primary psychotic disorder, or is it really more of a chronic substance induced psychosis? And so there's not really a good agreement on that. But technically, if we're going to look at the criteria, if they've not used for 6 months and they've not and they're still psychotic, then it would then be technically as a primary psychotic disorder. um, Interestingly, the symptom presentation tends to remain the same as that of prior episodes. So if you see somebody that comes in intoxicated on methamphetamine and they have, persecutory delusions or paranoia that, somebody has cameras and is watching them in their home, you may see them months later when they're intoxicated and they may have that exact same delusion, or that exact same, very similar presentation. Um, we do see that there's sensitization or reverse tolerance effect, meaning that there's a shorter period of time between the use and psychosis or psychotic symptoms developing when people use for a longer period of time. So there is, again, that more people that use longer are going to be more prone ultimately to psychosis. And of note for us, especially, is this last point that there are higher rates of health service utilization, including hospitalizations, for those who are, develop methamphetamine-induced psychosis versus those without psychosis. We see this a lot in EPS, where somebody comes in and is intoxicated on methamphetamine, not safe to discharge home due to their degree of paranoia or their, lack of reality, sense of, being present in reality. And so we end up, admitting them to a holding bed, and then they stay with us overnight. And, so we have a lot of kind of hospitalizations, even if it's just more of an observation, that are a result of this methamphetamine induced psychosis. So kind of discussing, how do we manage the acute intoxication or toxicity of methamphetamine? So we know that obviously we can use antipsychotics to manage agitation and psychosis. Based on the information I read, there's not really necessarily a one, that's superior to the other for this situation. Oftentimes you'll see second generation, such as Risperdal or olanzapine, that are used. Um, Benzodiazepines are kind of the mainstay for managing, agitation, insomnia, tachycardia, and elevated blood pressure. So this can be really beneficial both from a psychiatric standpoint as well as a physical health standpoint, addressing some of those effects on the cardiovascular system that we talked about that can result from methamphetamine intoxication or toxicity. If somebody has rhabdomyolysis or acute kidney injury, we can treat them with IV fluids. Cardiovascular monitoring can be indicated. Of course, we don't really do this so much on the psychiatric side. However, if someone is complaining of chest pain in the context of methamphetamine use, they're probably going to be on the medical side of the ER anyways. And over there, they're more able to kind of monitor those sort of things and make sure that there's not development of some sort of myocardial infarction or arrhythmia, something else that would warrant further medical care. And lastly, if they're hyperthermic, you want to utilize active cooling because, like we talked about, the hyperthermia can lead to end organ damage. And so, really, kind of getting a handle on that sooner rather than later is very significant for our patients. So we know that, in addition to there, being acute effects or results that can occur from methamphetamine use, there's also a lot of effects that from chronic methamphetamine use. A lot of you, most of us have heard of meth mouth. So that's tooth decay as a result of methamphetamine use. So methamphetamine dries out the mouth when you don't have enough saliva or moisture in your mouth. That leads to tooth decay and damage. You're going to see this more typically in those who are smoking meth versus using it in other ways. Um, Additionally, skin picking. So, like we talked about previously, a lot of these patients have those tactile hallucinations where they feel like maybe there's something crawling, bugs or something under their skin. So that leads them to pick their skin, and you can see in some of these images on the right that they've a lot of these people who, as recently as 1.5 years prior, they didn't have all of these lesions that they have developed due to skin picking. Like we touched on, the psychosis related to methamphetamine use is not always just acute or temporary. It can become a chronic condition as well. Um, we do see that with chronic use, there's reduction in dopamine transporters, which results in impaired cognitive functioning, which would include reduced motor speed and impaired verbal learning. They did do some studies as far as kind of looking at if someone abstains from methamphetamine use, what happens to dopamine transporters. Over a short interval of time, there wasn't a huge rebound in the dopamine transporters. However, when people abstain for a longer period of time, their dopamine transporters did, kind of rebound and increase back to close to normal rates or numbers. However, there was not a correlating improvement in their cognitive functioning. So obviously, it's not as simple as increasing the dopamine transporters will resolve or reverse those cognitive effects related to long-term use. And lastly, there are structural and functional changes to the striatum that result in emotional and cognitive issues and decline in mental flexibility. So, we'll see oftentimes that even if somebody has abstained from methamphetamine or not recently used, if they do have chronic use, they have that kind of affective lability or mood lability that kind of becomes a chronic condition for them, and they may have more issues with anger and things even outside of the context of when they're using. And lastly, looking at these photos, we can see that it ages you a lot. So, this first gentleman, it was only 7 years difference between these photos. The next lady, 1.5 years, and the last lady, 2.5 years. So, and they look far different than they did in their initial photos. So, some factors that are associated with methamphetamine use include being a male, age 26 or older, having a lower educational attainment, a household income of less than 50,000, being on either Medicaid only or not having any health insurance, residing in small metro or non-metro areas. Um, Geographically, if you're in the West, it's more likely use, versus the Midwest versus the South versus the Northeast. And then lastly, housing instability and homelessness. Obviously, the instability and homelessness, we see that, a lot of these criteria, truthfully, we see in EPS when we have patients that come in with methamphetamine use and methamphetamine induced psychosis. Um, like we talked about with a severe use disorder or dependence, really a lot of those criteria for a use disorder are focused around, people not being able to function as well in society, whether that means, work or home responsibilities and things of that nature. And so it's kind of a vicious cycle in the sense that, um, you know, their lives become so much more focused on using and attaining that substance, that then a lot of kind of their other responsibilities and things that are important in the lives of a lot of us kind of go by the wayside. And so ultimately what ends up happening is, they can't, pay the bills, they can't hold the job, they can't do those things. And so that ends up leading to this instability and homelessness that we see, which is becoming an increasing issue across the United States. So we're going to shift gears a little bit and talk about some of the trends in the United States with methamphetamine use. Of note, there is the data that I was able to find is primarily in those either who are receiving treatment or have presented to the medical, hospital or ER, something like that. As you can imagine, it's much more difficult to do studies on and gather information on patients who aren't in treatment or who haven't sought out some sort of medical treatment, um, just due to, how do you get a hold of them? How do you get that information from them? So most of this data will be from people who are either, in a treatment for substance use or, have presented to the, some sort of medical entity. So in discussing, this is going to be for treatment population, so people who actually sought out or were referred to specifically substance use treatment. In a study done that analyzed data from 2010 to 2017, they found that people reporting any methamphetamine use, so this would be in addition to, other substances that they may be using, it rose from 14.1% to 23.6%, which is an average annual growth of 8.8% per year. Additionally, for those who reported that methamphetamine was their primary drug of use, rates rose from 9.4% of admissions up to 14.5% of admissions, which correlated to an annual growth of 7.4% per year. These increases occurred, among nearly all demographic groups. So we see that, there isn't any really significant trend. This is kind of a widespread national issue, and that, it's really increasing across the board use. Methamphetamine injection increased. We kind of talked about that previously. And there were characteristics that were associated with increased odds of reporting the use at admission, which included being a female, age range of 35 to 44. You can see specific locations where people may be, it was linked with, unemployment, not being in the labor force, having, variable housing situations, namely, being homeless, and then referrals from various entities. Additionally, and of note, from 2015 to 2018, fewer than one third of adults with past year methamphetamine use disorder received substance use treatment in the past year. So we've got, an increasing rate of people using methamphetamine, and we have a very, very small fraction of those people in recent years who are actually receiving substance use treatment. What we don't know about this number is that, due to lack of resources, which arguably it could be, or is that due to lack of desire to receive treatment? Something to think about. So this is just a graph sort of representation of or chart form of the information we just talked about. The big takeaway from this is that we can see that on our y-axis, we've got our percent of drug-related treatment admissions. This is going to be for methamphetamine specifically. And this just kind of looks at different demographic criteria. So we see that we've got, comparing genders, age groups, ethnicity or race, and then as well as location. For our purposes, the big takeaway of this is that from 2008 to 2017, regardless of how you analyze the data, the reported use of methamphetamine is on the rise across the board. No matter how you analyze it, you look at it, you break it down, it's increasing. So we'll take a look now at overdose rates from methamphetamine. This is going to go from, I think, 2011 to 2018. So the legend here is going to indicate that the gray or the less purple indicates a lower rate of overdose, whereas the more purple a state is, the higher the rate of overdose. And so we'll just kind of briefly look through these year by year and see kind of what the trends are. So not surprisingly, we see initially that as of 2011, mainly the West Coast or Western states are affected again. That's probably due to where the substances or methamphetamine is coming from. It's coming from Mexico. So obviously it's going to be more accessible or easier to transport or traffic to those Western states. So as we kind of move through time, we see that the use or the overdose rates are becoming more and more common. And not only just in the Western states, but they're gradually moving across the whole United States to the point of, where we end up in 2018, where there's really not a state that doesn't have some degree of purple anymore. And we see that it really, as some of those other studies showed, that the West and the Midwest are really the most common places for increased use, which probably does correlate with increased overdose rates as well. So taking a look at some more information or studies that have been done, specifically taking a look at overdoses in the emergency department. So this is for amphetamine type stimulants. So this doesn't necessarily specify for solely methamphetamine, but when we look at this data from 2015 to 2016, ED visits and inpatient hospitalizations for non-fatal overdose increased by about 11%. So about 11% increase in just 1 year's time. Additionally, methamphetamine accounted for about 64% of amphetamine involved ED visits in 2011. So we know that since 2011, the use of methamphetamine has rose significantly. So we could only assume that probably this number, this 64%, would be quite a lot higher, as far as amphetamine related ED visits as compared to in 2011. And so kind of looking at this figure down below, what this does is this is going to take a look at over the course of the years that they collected the data and, the rate of overdose per 100,000 people, population. So we see that from the range that they looked at this information initially, we'll look at from 2010 to 2015, that the odds of any amphetamine type stimulant overdose involved ED visit increased by 11%. So the difference between, the any is basically suggesting that the person again may have other substances that they've utilized as well. So it's not solely amphetamine type stimulant. So it could be, for those folks that maybe, had methamphetamine laced with fentanyl or used both opioids and amphetamines, which is becoming a more and more common issue in the United States as well. We see that for those where it was only attributable to amphetamine type stimulants, that there's an increase of 7% of overdose involved visits in the ER. When we look at 2016 and 2017, again, looking at those numbers for any amphetamine type stimulant overdose, the rates increased by 19.1%. And then for only amphetamine type stimulant overdose, the rates actually increased by 20.5%. There is this gap in the chart due to the change in ICD-10 diagnoses. So they had to kind of reevaluate what diagnoses they were going to utilize in order to come up with their data for this study. So that's why you have that break in the scale. But again, the big takeaway from this, regardless of the specifics numbers, is that we see that the number of overdose related visits to the ER has been increasing almost exponentially in recent years, and likely, since 2017 that trend has probably continued. So we know that, methamphetamine overdose isn't just, just an overdose. We know that, like we talked about previously, it can lead to death as well. So, especially via those cardiovascular mechanisms, including, heart attack, strokes as well, are a possibility. So, in looking at the overdose deaths, we see that drug overdose death rates that involve psychostimulants increased greater than 300% from 1.2 per 100,000 in 2013 up to 5 per 100,000 people in 2019. At this point in time, psychostimulants are the second most common drug class involved in overdose deaths, right behind opioids. So some other kind of data on overdose death rates from 2012 to 2018. Amphetamine type stimulant involved overdose death rates increased on average 30% per year. Methamphetamine involved deaths have rose from 1,887 in 2011 up to 9,356 in 2017. So that's a massive increase in a matter of 6 years' time. And lastly, these increases in deaths have been seen across geographic regions and demographic groups, which we've talked about, for overdoses in general and overall use of methamphetamine as well. So there's really no one that this isn't affecting, as far as this is a widespread issue and problem for us in the United States. So you can see this represented again in these figures. And so again, our big takeaway, from this is that this is looking at, breaking it down via gender, into gender, and then also ethnicity. But for our purposes, again, the big takeaway is that everybody's uptrending. Everything is going up, and so of course that's quite concerning. So taking a look, at sort of the socioeconomic burden that's affiliated with methamphetamine use, there was a study done in 2018 that estimated that $390.2 million was spent on methamphetamine-related heart failure admissions in California, and 6.1% of that was 6.1% of all of their heart failure admission costs in that state for that year. So, we're seeing again that, there's a massive amount of money via, whether it's, an overnight stay and for psychiatric reasons, or, a full hospital admission for medical reasons as a result of methamphetamine use, that this is becoming a huge expense and burden on the healthcare system. There's a study done in 2005 by Rand Corporation that kind of did a national assessment of costs related to methamphetamine, and they estimated that it's probably between 16.2 and 48.3 billion dollars per year, in costs that have been related to methamphetamine. And that was in 2005. So we know that, based on what we've covered so far, that rates have only increased since then. Overdoses since then have increased. Health service utilization has gone up. So we can only imagine what that number would be these days. They base that figure on estimated costs of healthcare use, productivity losses, methamphetamine-associated crime, production of amphetamines, intangible burden borne by those addicted, as well as child endangerment. So we did kind of touch on, also the burden or the result of, link of methamphetamine use and homelessness and issues with sort of stable housing. Additionally, we kind of touched on, and just wanted to reiterate again, that the productivity losses. It's very difficult to hold a job when you're utilizing a substance or addicted to a substance like methamphetamine. So again, just reiterating, this cost is likely increased substantially due to the increasing prevalence of methamphetamine use across our nation. There were approximately 1.3 million amphetamine-related hospitalizations in the United States from 2003 to 2015. And of that number, it was shown that, there was a huge increase in the number, at 2015 compared to that of 2003. So there was a substantial increase over that interval of time that was looked at as well. It was seen that in that study that the highest frequency of methamphetamine related hospitalizations was in Western states, and that the predominant payer was Medicaid. So we'll talk a little bit about treatment options for methamphetamine use disorder at this point. Um, so one treatment modality or method that has been shown to have some benefit based on studies that have been done is the matrix model. So what this does is it really kind of incorporates various CBT principles. The person's kind of involved in individual and in group sort of therapies, and the goal is really to help them to reduce their use or facilitate abstinence by teaching them, relapse prevention skills, such as include, drug avoidance, identifying triggers for substance use for them, and learning, how to refuse or say no to the substance. In the studies, it's been shown to have strong efficacy in reducing substance use and improving functional outcomes as a primary treatment approach. And additionally, it's been shown to be beneficial when utilized as an augmentation for other modes of treatment, including pharmacotherapy, for instance. Another uh, treatment modality or technique would be contingency management. What this does is it's really kind of a reward or an incentive program. So basically, in this, you try to reinforce positive behaviors, which would be something like a negative, urine drug screen um, or attending, treatments that are required or group therapies, things of that nature. And so, either, cash payment or vouchers or something of that nature could be used to try to encourage people to continue on that path of making the right choices and doing well. And so this has been demonstrated to significantly reduce methamphetamine use with optimal efficacy associated with longer intervention duration. Of course, there's a classic sort of 12-step meeting NA/AA sort of approach that has been shown to be a benefit for many people. And lastly, as we touched on previously, there are, a host of, comorbid psychiatric conditions, depression, personality disorders, anxiety, psychosis that, can be comorbid to methamphetamine use. So treating those comorbidities can also aid people in ultimately being able to abstain from methamphetamine substance, use. So taking a look a little bit more at pharmacotherapy, there are actually no medications that are FDA approved for the treatment of methamphetamine use disorder. So many have been studied over time. I've only mentioned a few here that have shown some possible benefit, although nothing is overwhelmingly supportive at this point in time, resulting in, of course, there not being any really FDA approved medications. So we'll kind of just walk through some of these that have been shown to possibly have benefit in the studies, but really ultimately everything here probably needs more research before actually saying that, this for sure we can say is really beneficial for these people with this disorder. Wellbutrin is one thing that's been studied, found to be particularly helpful for those who have, comorbid depression or ADHD, and has been kind of hypothesized to help with withdrawal or, more vegetative symptoms associated with withdrawal due to increasing the amount of dopamine. So some data has shown that, in combination with the behavioral group therapy, it helped to increase the number of weeks of abstinence in those who had low to moderate methamphetamine dependence. So, helped with some people, but in that study, it was not shown to have any clinically significant benefit for those who had severe methamphetamine dependence or disorder. Next, we have naltrexone, which is an opioid antagonist. It's thought that maybe this can help by attenuating reinforcing effects of substances or cue-induced cravings. There's a study done in 2021 that looked at Vivitrol or injectable naltrexone in addition to bupropion ER, extended release. They did have a response of 13.6% compared to 2.5% with placebo. How they monitored this was, or primary outcome was, the person having at least 3 meth negative urine drug screens out of 4. Mirtazapine has been looked at. As a reminder, it's an atypical antidepressant that increases monoamine levels. Thought that it could alleviate cravings and withdrawals. They found in the study that was done that it may reduce methamphetamine use, it likely does, but it didn't really seem to improve, retention in treatment or depression symptom severity. And lastly, methylphenidate has been studied with some reported positive studies or results. As a reminder, it's a norepinephrine dopamine reuptake inhibitor. There've only been small studies really conducted, and it seemed like it was particularly or more helpful for those who have been diagnosed with ADHD. And really larger studies would need to be done to really justify this. It's interesting. I mean, you could make the comparison of using a stimulant to treat a stimulant use disorder, sort of like we do with opioid use disorder. However, things I think get a little bit more complicated in using a stimulant to treat something like that, because as we've spent so much of this presentation talking about, there's psychosis that can be resulting, from amphetamines as well as, methamphetamine. And so, you're kind of walking a fine line, or maybe, I think it would be difficult as compared to, treating someone with, a heroin addiction with Suboxone or methadone. I think that there's a lot more kind of, it'd be a lot trickier, I think, to do with a stimulant and to treat a stimulant use disorder. And lastly, unrelated to methamphetamine use disorder, but did just want to touch on that, if someone does have a chronic psychosis as a result of methamphetamine use, of course, we can use antipsychotics to treat that with typically decent benefit and improvement. So specifically in Kentucky, there are a couple of, there's this program that's called Recovery Kentucky. And this is kind of geared to help those with substance use, not specific to methamphetamine, but just substance use across the board in the state of Kentucky. It began in 2005. It's a joint effort by Kentucky Department of Local Government, the Department of Corrections, and Kentucky Housing Corporation. At this point in time, they have 18 centers across the Commonwealth. These centers are not actually government centers. They're privately owned facilities that have contracted with this program. And what they'll do is they provide housing, care, and programming. So a good example of I'm not sure if the Healing Place here in Louisville is part of Recovery Kentucky or not. I struggled finding a list of the specific facilities that was up to date. However, imagine something along the lines of that is sort of what these treatment programs are like, where somebody has, stable housing. They participate in oftentimes, the sort of 12-step program. And then eventually they can progress to, being able to, find employment or becoming a peer support for other people who are entering the program. So they can provide services for up to 2,200 people at a time. That's great, and it's a great resource. But as you can imagine, 2,200 in the scheme of things, even for the state of Kentucky, is really not a huge number. There's a lot more need in our state than what this alone is able to provide. So this kind of, again, the orange down below sort of reiterates what I just talked about as far as the overall kind of treatment plan or the kind of process through Recovery Kentucky. So you get people safe and off the street. They kind of assess their motivation to, remain clean or to receive substance use. They work with them on, accountability and responsibility, and as well as that 12-step program. And then ultimately, if they continue and stick with it, then they can eventually become employed or become peer mentors. The gray up above sort of tells you how they have evaluated some of the progress or results of the program thus far. So what they do is, if somebody, is willing to, progress to phase 1, then what they'll do is they'll do an intake assessment for them. And then they're kind of agreeing to do an outcome evaluation later on. So that outcome evaluation is done 12 months after the intake. So we'll take a look briefly at some of the data that they found in recent years, from these follow-up assessments as compared to that intake. And just, again, that's a 12-month interval of time during which the patient is in the program. So in this figure, it's kind of looking at when somebody came into and started the Recovery Kentucky program, for opioids and methamphetamine, who was using, what were they using 6 months prior to entering the program. And so this looks at, data from 2010 up through 2021. And again, for our purposes, the big takeaway is that we see that this light gray line for methamphetamine over from the time from 2010 up until 2021 has been gradually in, there's a couple dips, but ultimately has been uptrending. So this again kind of shows and is representative of the fact that in the state of Kentucky, we're seeing that rise in methamphetamine use as well. So this is some of the data that they have found based on recent, evaluation of that. And again, it's going to be from about this data is cumulative from the past, few years or so. And so really what they're looking at is past 6 month substance use. And then we've also got past 6 month mental health. They looked at a lot of other measures too, but I just picked out a couple that I thought would be significant for us. So we can see that across the board, they have shown, benefit as far as people abstaining from substance use. Particularly, we see that for meth, it went from 64% at intake. And again, that would be use in the last 6 months. And then down to 7% use in the last 6 months at the follow-up 12 months into the program. Additionally, we see, like we talked about, a lot of these comorbidities, including depression, anxiety, and additionally suicide ideation or attempts. Everything has reduced with this program. So the program, overall, shows great results for those that stick with it and are able to stay in treatment. But we know the reality also of substance use and methamphetamine use is that it can be difficult to stay clean, and it can be difficult to stick with the program. And so it can be a great resource for some, but getting people who are really motivated to stick with it and implement the changes needed can be difficult. On that note, there is, Tim's Law in Kentucky. A lot of us have probably heard of this, but just wanted to briefly touch on it. So this is really the only means of, getting someone other than, court-ordered substance use treatment in Kentucky. So it allows for assisted outpatient treatment, or AOT is what it's called, which is an evidence-based treatment for serious mental illness. The court orders the patient to follow a treatment plan while they're living in the community instead of in a residential treatment facility or psychiatric hospital. So the goal of this is really to assist people, reduce hospitalization and the expenses related to that, and to help people still get on the right track as far as substance use. As you can imagine, it's a bit difficult because you're forcing someone into substance use treatment, and we know that oftentimes people don't stick with it, or there isn't necessarily long-term sustainable change or positive change when the person isn't ready, or it's not their decision to undergo something like this. So the process of going through or getting Tim's Law, if somebody was interested in getting that for a family member or someone else, they would have to file a petition, and that petition has to kind of make the case that the person they're filing it for has a serious mental illness and will, without treatment, present a danger to themselves or others, suffer severe mental, emotional, or physical harm, have impaired judgment, reasoning, functioning, or capacity to recognize reality, have a substantially diminished ability to make informed decisions regarding their need for sustained medical treatment. And of note, the individual must have a lack of insight into their own illness, and they have to have been hospitalized within the past, twice within the past year. So again, this is sort of a means to try to cut back a bit on hospitalizations. So I wanted to touch briefly on the future of treatment for methamphetamine use disorder. So there are a couple things sort of in the works that have been for quite a few years now that are being explored and researched, one of which is anti-meth vaccines that are being developed. For these, the key has really been achieving a high antibody response. So obviously, the same with these and monoclonal antibodies is you want to be able to have a high enough antibody response to kind of combat the effects of the methamphetamine. And monoclonal antibodies that bind to methamphetamine have also been, significantly studied by various, companies or entities. So there's one study that's been done. It's called the STAMP OUT, or Study of Antibody for Methamphetamine Outpatient Therapy clinical trial. That's for a medication that's been named IXT-M200. So they did have a phase 1 study, and during that, they did not see any serious adverse reactions to the antibody. The half-life of it was about 18 days, which meant that, potentially it could, remain at, steady state or therapeutic blood levels if, it was dosed every 3 to 4 weeks. Currently, they're conducting a multiple dose study to evaluate the safety and efficacy. It's a phase 2 study that's estimated to be completed around December of 2024. So we'll have to stay tuned on that. But there are fortunately some, potentially more effective treatment options on the horizon. So here are kind of our conclusions. A lot of this is just kind of reiteration. So in the interest of time, I really just want to say that, the main conclusion that I have based on, all of the information that we've covered today is that we really need to continue researching, treatment options for methamphetamine use and methamphetamine use disorder, because, we see this increasing rate of use in the United States and significant detrimental effects as a result of that use, including, overdose risk, other health and psychiatric risks for individuals, and as well as a lot of socioeconomic burden affiliated, particularly increased costs and utilization of the healthcare system, increased homelessness, lack of employment, things like that. So, the questions that I would pose to the group for our kind of discussion are sort of, what do we do when there are rising rates of methamphetamine use, lack of resources, and limited treatment options available? And additionally, just kind of circling back to amphetamines being used for ADHD, do we think that there's any significance to amphetamine type stimulants for ADHD contributing to the growing rates of methamphetamine use in the United States? We saw that back in the 20s to the 70s that we had this iatrogenic sort of epidemic from amphetamines being, offered over the counter and prescribed. And while I think that probably in this day and age, there is a huge significance to methamphetamine coming from, from these drug traffickers and everything, and that's the vast majority. I think, as physicians, we always need to keep in the back of our minds too, what are we doing to either, possibly contribute to the problem or to help to prevent it from continuing. So with that being said, here are my references, and I will go ahead and open it up for questions and comments.
We have a couple of hands up in the meeting room. Let me see if I can get them over to speaking roles. Dr. Rabbani first.
Okay. Yes. Thank you very much for this really informative talk. These residents are excellent, really, all of them, with all these good grand rounds you are giving and all good information you are giving us. So anyway, my question is mainly about you mentioned the treatment, and there are lots of progress in treatment, and even they are looking for vaccines to them. But who is going to? They are going to self-medicate themselves to be happier. They don't want to use vaccine or something, not to. I mean, that is the important thing. With many of these and you mentioned that this is more in those who are in lower socioeconomic condition, and that they get they do abuse of this and also other alcohol and other substances the same. So we are always hearing about the treatment after they are broken. They are in that state. Whatever CBT and this and that, and even if you, I don't know, they cannot give them housing that much. You mentioned something about the recovery, but even that, when they are broken, there are so many bridges has been destroyed. The improvement of these people is very low, whatever we do. So we never hear about prevention. What should we do for people not to get to these states? Socioeconomically, in the United States of America. I mean, for example, education, universities should be free for all people, for that people can have all access to a better life. For example, you know what I mean? In the schools, they should teach them to take hardship, not for any small reason, to use substances to make themselves happier. Things like this, we don't see much progress or thoughts about these kind of things. So I don't think if you can answer my question, but in general, I was thinking about these things. So thank you.
Of course. Yeah. I mean, you raise a very good point, and I think it is difficult because I think a lot of, substance use, the reality is that, they may have been raised in an environment where other people, the adults or their parents, were using substances. And so that's just kind of a learned behavior in a lot of instances, or a means of coping with traumas that have happened in their childhood. And so I guess you could argue by that reasoning that, seeking and getting, treatment sooner, for, some of these probably comorbid, diseases or disorders that are affiliated with substance use, regardless of what substance, would be a great start. But the reality of that occurring and a family member who may be using substances themselves, a parent, or, have their own things going on, taking a child for that treatment is also kind of not likely. So, I mean, it's tough. I don't know what the answer is, but it is a really.
Yes, and I am even talking beyond that. Even those families who are socioeconomically low, we should help them to go up. They should have, before these families get to the, to that condition, then that they are self-medicating themselves that way. And then the children in those families would be broken also, and all those things. I'm talking about more than that even. So thank you.
I think Dr. Wong may be on the call.
Hi, Laura. Hi. Can you hear me?
Yeah, I can.
Yeah. So very nice talk. I really enjoyed it. I just want to mention, so this year at APA, there is a talk on brain and drugs. So the guy, he measured like an increase in dopamine release. So in general, like heroin, nicotine, other stuff only double the dopamine level in the pleasure pathway. And then amphetamine increased by 10 times. So that was pretty dramatic. And then another thing is like, you mentioned about this kind of iatrogenic kind of, effects. And then so I went to a local talk. In the morning, there was a marijuana researcher. She was talking about different brand names for marijuana, like Morning Breeze, like Morning Dew, Sea Breeze, that kind of thing. And then in the afternoon, there was a psychiatrist, and then he talked about all the different brand names of amphetamine, and then because there was a shortage of Adderall. And then he was saying you can use different, but this, he doesn't sort of I mean, there's no self-reflection, there's no sense of irony. He really sounds like a marijuana salesman in the afternoon. And so another thing is like in the literature, I think there are people insisting there is a difference between methylphenidate and amphetamine. They claim, people don't get high on methylphenidate. Have you come across any data on that in that regard?
I have not specifically, so I can't speak to that. I'm not sure.
What about Strattera? Is that used as some sort of replacement treatment, for this kind of stimulant abuse?
It's not, as far as I saw, that's not specifically been studied, or at least, not anything. I think it would be, probably reasonable to explore that and see, but I didn't find anything as far as Strattera or any SNRI really being specifically looked at for methamphetamine use disorder.
Gotcha. All right. Thank you so much.
Yeah.
Hi, Dr. Crump, can you hear me?
Yep.
Yes, well, great talk. Really did like this topic. I guess my question is, I apologize if you had mentioned this before, what it is when they look at the demographics and look at kind of the of who's using, amphetamines, methamphetamines, at what age are they using? The average age that they're starting? is this something that can be traced back to like something that started in childhood, or is it something that the average age is like a young adult?
It varies. So typically we see that, as far as developing a use disorder, it's more into like the mid-20s and onward that somebody's more likely. But as far as the initiation of use, like there have been studies done looking at, and I don't remember the numbers off the top of my head, so I apologize, but that there have been, in some of the studies, they'll look at just the overarching use, and even in childhood and adolescence. And so while I would say that it's definitely not the vast majority of people, those numbers were significantly lower than when they looked at, sort of the more adult population. There is still a fraction or percentage of people that are using amphetamines, in their adolescence or even as early as childhood. I can't really put a specific number on it. Obviously, the use of amphetamines in those studies is a lot lower in that kind of child and adolescent age group as compared to a lot of other substances, such as, cannabis, for instance, that the rates of use in that age group are significantly higher.
Thank you.
Mhm.
You do hear the anecdote a lot of times that I was prescribed Adderall when I was 3 or 4 years old, and now I'm addicted to methamphetamine today. And it sounds very similar to someone who says I was prescribed opiates after a procedure, now I'm addicted to heroin. So just going on that and the iatrogenic potential for increase in causing stimulant abuse. Do you know if there's any type of class action lawsuit against Adderall, similar to like the Purdue Pharma?
Not that I'm aware of, no. We'll see with time. I mean, it would be interesting to see if anything like that occurs. But as far as I know, there's not been any, sort of legal pursuits or, anything major in that regard as far as, perhaps the causation of or, leading to, illicit substance addiction from, prescription medications.
So it sounds like an opportunity.
I think we have Dr. Vincent also with a question or comment.
Yes, Laura, thank you very much for this talk. I really did enjoy it. And I struggle myself with prescribing stimulants because it seems that in the last few years, I've had a significant number, an increase in patients coming in specifically asking for stimulants. And I'm looking at the wall behind you. You've got that large poster on your wall that shows all the stimulants. And for those attending who don't have that poster, it's front and back of all the available stimulants, including the dosages to prescribe and what they look like. I'm just wondering too, as Dr. Ive had mentioned about the use of Adderall and the potential for abuse. And I recognize that many things in the world have changed since the pandemic and even before the pandemic. I think the internet, the short news blurbs that people hear and read online, you have to have rapid attention and concentration and to keep up with what you're reading. And so people are chasing something. I'm seeing more and more, not older. I'm seeing more and more people in their 30s, 40s, 50s coming, never being diagnosed with, who are wanting a stimulant. And I almost always start with something else and assessing the comorbidities, because there's a tremendous amount of anxiety underlying a lot of their symptoms. So I always want to start with something to work on their anxiety and their depression, their mood symptoms, and that's not what they want. I actually had a patient say to me, Dr. Vincent, how come you won't give me a stimulant? My friends get their stimulants from their doctor on their first visit. So have you had any, in your readings, did you really see anything that tied this increase in use to the pandemic or the internet or the need for, or even working from home? Because it takes a different type of concentration to work from home than you have in an office.
I did not see anything specific on the internet or the pandemic or specifically working from home. What I will say is that, the overarching themes is I think at this point, a lot of it is being attributed to, the increased potency of it, coming in from, being trafficked and things. So I think at this point, that's kind of based on the readings I found. But then again, these are all things that, not to say that they're outdated, but they're also from, a lot of this literature that's been published recently is from, before 2020. A lot of those studies we reviewed are from before that time frame. So it may just be just like a lot of other things where, we need a little bit more time to really delve into those things, and hopefully there'll be more information and things published. But like you're saying, I couldn't imagine that. I imagine there's some correlation or some association of a lot of what you're describing to, the rise in use as far as the fraction of what's due to increased illicit, accessibility versus prescription accessibility. I don't have a good answer to that at this point.
Thank you.
We are at the end of our time. Thanks to all of you for attending. Dr. Lippman has once again graciously extended an invitation for you to convert this into a scholarly article, which I would encourage you to do. And we will see you all the next academic hour.